Good morning, everyone. My name is Dr. Sanjay Prabhu. I am a neuroradiologist at Boston Children's Hospital, and I thank the ASPNR for giving me the opportunity to speak to all of you today. The topic of my talk today is imaging of hemispheric disconnections, the past, the present, and the future. The objectives of the talk are to enumerate various hemispheric disconnections and show you ways to optimize your preoperative, intraoperative, and postoperative imaging studies designed for these patients, and recognize the incompleteness of disconnections and look at the post-op studies and recognize complications in these patients. Now, let's start with these three scans here, three different patients. And when you see these scans, what comes to your mind? Does it strike fear in your heart and you feel you want to pass this on to your colleague? Or do you want to just say post-op changes, next scan, please? So if that's the case, then this talk is for you. At the end of the talk, hopefully you can see what's wrong or what's right about these scans. Let's talk about the types of epilepsy surgery. You can have focal resections, we have open resections, lobectomies, and lit procedures. You can have disconnections, where you have either hemispheric disconnections or more focal disconnections, and ablative surgeries like hypothalamic hematomas, where you can do resection using laser now, or you can have neurostimulation, which includes VNS, RNS, and DBS placement, or deep brain stimulation. And in today's talk, I'll specifically concentrate on disconnections and also hone down on hemispheric disconnections. So disconnections can be divided into either hemispherectomies or other disconnections. Hemispherectomies are divided into two different varieties: the anatomic hemispherectomy or the functional hemispherectomy or hemispherotomy, slightly different surgeries, but they come in the same category. And then you have unilobar or multilobar disconnections and quadrantectomies. And then you have callosal surgeries, which can be the complete callosotomies or anterior or posterior callosotomies, and also minimally invasive callosotomies. For today's talk, I will concentrate again just on hemispherectomies specifically. The indications and selection criteria for hemispheric disconnections are, as an overarching thing, would be poorly controlled unilateral epilepsy, which is not focal. So if you have a large hemispheric lesion of some sort, either it's due to a perinatal stroke or some congenital condition like Sturge-Weber syndrome or dysplastic megalencephaly, or you have an acquired condition like Rasmussen encephalitis or post-traumatic epilepsy or post-infective epilepsy, or if you have these diffuse cortical malformations affecting the entire hemisphere or even more than a hemisphere, those are the patients who you consider for hemispherectomy surgeries. Choosing a surgical option requires one to think about the pathology, semiology, developmental status, and age of the child. The pre-op considerations, you want to see that there are multifocal widespread abnormalities in the EEG, and there's a detailed assessment of the imaging, which we'll talk about in the next couple of slides. The patient undergoes neuropsych evaluation and other tests. And note that language localization is usually required in patients who are more than 4 years of age. Having normal motor function is a contraindication because patients will lose a motor function once hemispherectomy is completed. Normal visual freeze is a relative contraindication, and sometimes the patients and the parents may choose to lose a bit of vision to get seizure freedom. This discussion occurs at a multidisciplinary meeting, and once that's done, you move to the next stage for surgery. During these conferences, you do get the images for review. And I would say what I've learned over the years is the assessment of the contralateral hemisphere is key. Bilateral disease on imaging is a relative contraindication to what we call curative hemispherectomy or hemispherotomy. Once you have bilateral abnormality, the likelihood of seizure freedom comes down significantly. So this is an example of a child who was about a month old, had a very abnormal looking right hemisphere, read as hemimegalencephaly. But I thought this was more like dysplastic megalencephaly, where the other side was also abnormal. And we did warn the surgeons about this, and they went ahead and tried the procedure because the parents wanted to try this out. Once the surgery was completed, the patient developed seizures from the other side and had subsequently had to be treated for that as well. So the other side is the key. In addition to looking at the the contralateral hemisphere, you also want to look at the extent of abnormality, see if there's an option for a more focal procedure like a quadrantectomy or a disconnection procedure, which does not involve the entire hemisphere. Also look for clues for other disorders like metabolic or mitochondrial conditions or genetic disorders, which then will raise concern because you might have a more global process affecting both hemispheres. The next thing to look at is the ventricle size. Look for any signs of brain atrophy or hypertrophy, and then look at the callosal morphology. Is there any callosal dysgenesis or some kind of callosal anatomy variation that you should warn the surgeon about? And finally, talk about vascular connections and look at the vascular anatomy, for example, azygous, anterocerebral artery, etc., which are used as landmark for the surgeons to locate structures. Let's start with endodontic hemispherectomy. The history of this procedure started in the 1920s when Walter Dandy started doing this surgery for patients with brain tumors. He's the same Dandy of Dandy Walker fame, and the patients did not do significantly well. That they did for a couple of years. The longest the patient lived was about 3.5 years. But at that time, before anesthesia and post sepsis antibiotics, etc., were available, this was pretty commendable. In 1938, Mackenzie in Toronto operated on this patient who was a 16-year-old female, and his patient was seizure-free after the procedure. He was only trying to take a brain scar out, a small area out, and ended up taking the entire hemisphere. So it wasn't a planned procedure, but nevertheless, the patient did really well. In the 1950s, there was a surgeon in South Africa called Krynau who published this large series of patients with infantile hemiplegia, and this led to a popularity in the procedure for a while. But in 1960, Oppenheimer and Griffith noticed that patients with post-hemispherectomy developed these complications of superficial cerebral sclerosis and hydrocephalus on autopsy, and many of them died. So surgeons came up with strategies to minimize the complications. This is how we came up on the more recent modification to endodontic hemispherectomy, where the surgeon clips and divides the major arteries, he then divides the callosum, does a frontal-basal disconnection, and follows the ventricle from the trigon to the hippocampus anteriorly to remove the hemisphere. This allows the surgeon to remove the entire hemisphere, and in some cases, you might leave the basal ganglia and thalamus behind. Alternative to this is called hemidecortication, where you take the cortex out but leave the bare matter structures in. This is a patient who had post-encephalitis seizures, and he had hemispherectomy, and he did very well. This is another patient with Sturge-Weber syndrome on the right side who underwent a hemispherectomy. You can see the basal ganglia and thalami left behind here. This is more a hemidecortication. And a few years later, he came back with follow-up a couple of weeks back, and you can see this deep gray structures are still present. Subsequently, in the 1970s, Rasmussen came up with the functional hemispherectomy, which is subtotal hemispheric resection. Instead of removing the entire hemisphere, he removed parts of the central and temporal regions while disconnecting the rest. And the frontal and occipital lobes, like I said, were preserved. These patients had comparable seizure outcomes and fewer complications. More recently, in the 1990s, two surgeons called Delaland and Villemure came up with this procedure of hemispherotomies, where you only disconnect the hemispheres without creating a cavity. So basically removing as little of the brain as possible. So you make these cuts in the brain, and then you disconnect the two hemispheres. There are two different approaches, the vertical approach and the lateral approach. And our surgeons in Boston prefer the lateral approach. In the lateral approach, you have 3 different stages: a suprainsular window, an infrainsular window, and an insular stage. This patient with the left frontal Rasmussen encephalitis underwent a functional hemispherotomy, and you can see the cuts here anteriorly and posteriorly, and here's the insular cut, and here's a temporal lobectomy. So this allows division of the splenium and the single limb here, and the frontal basal areas here, and the external capsule laterally. Of note, the erasmuscens continues to progress, and so those areas over time will burn out because of the disease process. Here's just a quick overview of the different types of hemispherectomies, and there are multiple different techniques used by surgeons, starting from the anatomical one to the more less resective, more hemispherotomy kind of procedures. In general, the resections are done subpially, and EVDs are not required in most cases. And most of these patients will require a post-procedural vent check examination. The surgeons use that neuronavigation, and so when you do the pre-op scans, you may want to include a scan which is compatible with the brain lab or stealth that they use for neuronavigation. One of the things to note is that if you have patients with large cystic areas, large infarcts, those lesions might shift, and the neuronavigation may fail at the time. On intraoperative MRI, you would look for immediate complications and complete resection with special attention to the genu and splenium. Here's an example of a patient with hemimegalencephaly on the left side, and the patient developed a significant swelling soon after the opening for the hemispherectomy, and the surgeon had to abandon the procedure and come back another day. At this time, they did the procedure here, and you notice here that the genu is still connected. So this was pointed out to them in the intraop scan, and they went back in and resected this area. Similarly, this is another patient here who had a similar process. On this one, you see both the splenium and the genu are both remaining, and so this patient had repeat surgery for completion of hemispherectomy. So assessment of completeness, you have to look at the frontal areas, the temporal areas with temporal lobectomy, the frontal basal connections, the occipital areas for the cingulum and splenium, and the insular region for the extreme capsule. Here's another example of a patient who had hemispherectomy, and here you can see the splenium was connected, and I showed this to the surgeon on the color FA map quite nicely, and he went back in and completed the procedure. Recurrent seizures can occur up to 40% of patients, and this happens in patients who have bilateral MRI abnormalities. This also occurs due to technical constraints and distorted anatomic landmarks. And typically in these patients, you have incomplete basal ganglia disconnection, and those patients are usually younger at surgery. It's more challenging to do the surgery in these younger patients. Postoperative imaging findings, you might see patients who have subdural effusions after hemispherectomy, or you might have assisted encephalomalacia, or you have more chronic subdural effusions without mass effect on later MRI scans. And occasionally you might need to have patients with hydrocephalus who need either a shunt procedure or some kind of CS diversion procedure. Occasionally you will see patients who have infection like this, and you might have big collections, and in this patient actually had ventriculitis. This is another patient here with shunt diversion procedure required. He had insisted has hydrocephalus, and typically hemimegalencephaly patients have the worst seizure outcomes and also the highest rates of complications. And this patient required an endoscopic ventriculostomy for drainage. The outcomes depend on the etiology of seizures. Seizure freedom is most, again, with patients with Rasmussen's encephalitis, Sjögren's syndrome, and infantile hemiplegia, and is worse in patients who have multilobar severe dysplasias and dysplastic megalencephaly. A recent advance is one of our surgeons recently did this minimally invasive laser interstitial thermal therapy hemispherotomy, which was quite commendable. It's a patient who was 5-year-old with a large perinatal infarct, who had comorbidities, and so he could not undergo a full hemispherectomy procedure. So to summarize, we have gone through the various hemispheric disconnection procedures and acquisition and interpretation of the preoperative, intraoperative, and postoperative studies. And hopefully you can recognize the incompleteness of disconnection complications in these patients. To go back to the original scans here on these 3 patients, you've noticed the first patient here The genu is still connected here, and so on this one as well. And this is another hemispherotomy patient here. And the third patient, this area was abnormal, but it was abnormal on the pre-op imaging. So this is not a complication. This is how the brain looked like before the procedure. So I thank you for your attention, and hopefully enjoy the conference. Thank you so much.